Hi, Deepa. Thank you for coming to Houston Methodist and visiting us. We really enjoyed your lecture that you just gave us on multimodality imaging and on chronic thromboembolic pulmonary hypertension. I know that with your extensive background and with your current position, you come in contact with many different CTEPH programs across the world, have been in large parts affiliated with their training and setting up their programs. So, as you know, CTEPH is a group 4 pulmonary hypertension. It recently, due to approval of riociguat, also known as Adempas, now first approved drug, we now have a medical treatment, but as you have so eloquently stated in your lecture, this is the only curative form of pulmonary hypertension, and where you can take somebody who is very symptomatic, functional class 4 on oxygen, to where they can restore to normal functional lives. So it's an amazing curative result that we can provide to our patients. However, as we know, there are many roadblocks in getting there. So my first question to you for your thoughts is, in your experience, not only the US, but worldwide and CTEPH in general, what do you think are or is the maybe the most significant barriers in our ability to provide this curative form of treatment to more wider number of people?
Myung, thank you very much, first of all, for having me here. It's a great pleasure to be in Houston. Now, with regards to your question as to what is the main barrier to patients reaching to the point where they need their treatment, I think it's lack of awareness. Lack of awareness of the disease, not just amongst the imaging people, but also among clinicians. Mm-hmm. It's fair to say CTEPH is rare disease, but I think it's more important to realize that it's an under-recognized form of pulmonary hypertension. And the problem is it gets misdiagnosed, or it gets underdiagnosed because people are not aware that there is a complication for acute pulmonary embolism.
Right.
And up to 50% of cases with acute PE can have a silent disease, and therefore when you come to the stage of a patient with unexplained pulmonary hypertension or unexplained dyspnea, the clinicians tend to think you haven't got a history of venous thromboembolism, and therefore you're unlikely to have CTEPH. And I think that's the first misconception. You don't have to have that history. The second thing is, if you've got a patient who has got persistent dyspnea of unexplained origin, the patients go on to have an echo. And where the echo is negative, people stop there. They don't tend to think of chronic thromboembolic disease, where your pulmonary hypertension has not had time to develop, but the patients have got still significant obstruction to their pulmonary circulation.
And more so young people too.
Totally.
Yeah.
And so I think there are two problems here. Lack of awareness on the clinical front, and then in the imaging front, people are not trained to look at chronic thromboembolic disease the same way as they are about acute pulmonary embolism. And this is because it's seen as an ivory tower diagnosis, is too specialized. And I think that's where we need to improve the educational aspects.
I cannot agree more. And I think your last comment is just so on the par, because it really need to start with medical school education really early on our training, and raise the awareness, as you state, up to the part of PE. People know acute PE, but when you mention CTEPH, you get this sort of empty look. What are those letters stand for? So, and the other thing that I know has come up in our conversation is, there's roughly about 500,000 acute pulmonary embolism cases in the U.S. alone, and I think conservative estimation of incidence about 3 to 4%.
Yeah, under 5%. Yes.
That is a huge number of people that are currently in evolution of developing or on their way to getting an advanced case of chronic thromboembolic pulmonary hypertension.
And where are all those cases?
And
where are the missing cases?
What is the best estimation of number of surgeries done each year?
In the UK, it's about 200 cases, but we are talking a small population.
And in the U.S., of course, the biggest center being San Diego and all the other ancillary centers, I think it's definitely under 500.
Yes.
And
so we are missing that group who are out there in the community,
yes,
for whom you are denying a curative treatment.
Yes.
And that is that I think is the main crux.
I must share with you, and you appreciate this. One of my most memorable memories is this young man in his late 20s who is a businessman traveling from Nigeria back and forth, developed chronic thromboembolic pulmonary hypertension, never knew it,
yes,
and he had syncope episode and ended up in the emergency room. Needless to say, his peer pressures were in the 120 range, severely hypoxic, had a beautiful response to the thromboenderectomy, to a point where he actually walked out of the hospital after maybe a week in the hospital.
And that's a phenomenal feeling,
isn't it? That is a phenomenal feeling when
yes,
you see
yes,
somebody near the brink of death,
yes,
and being able to restore, and not only restore, but just walk out with
yes,
their life fully intact. There's nothing like it.
It's very satisfactory.
And on the other hand, I've
yes,
also seen people where it was too late
yes,
in the recognition and diagnosis,
yes,
where they have end organ damage, their RV is just
irrevocably remodeled,
and then it cannot help them
you've
anymore.
lost that chance.
Yes.
And I think that is why it's very important to get the message out there, right from the primary care physicians through to
yes,
people who work in university hospitals. This disease is under-recognized. You need to be aware of the disease. It's okay to overcall rather than undercall, because we would rather make sure that we get everybody
absolutely
in the fold, and therefore we need to spread the message.
And to that regard,
yes,
just picking your brains on
yes,
expertise. So VQ scan, you touched upon that really well. It's underutilized. So I think your point about it is really a binary question that you're asking about a VQ scan. Can you just
yes,
comment
so
on
what
that?
you're looking for in a ventilation perfusion scintigraphy is perfusion mismatch. You have areas of reduced perfusion with preserved ventilation. This is VQ scintigraphy is the very sensitive test for telling you if somebody has got perfusion defect or not. The question that you want to ask is the perfusion scan normal or abnormal? And that's the binary form of this question. If it is normal, they are unlikely to have chronic thromboembolic disease as a contributory factor to their pulmonary hypertension. So when you have a patient with PH but normal VQ, you can take group 4 out of the equation and concentrate on the other 4 groups. If on the other hand, a patient with pulmonary hypertension has got a positive perfusion scan, then it's likely, very likely, they've got chronic thromboembolic disease. Now I'm saying very likely rather than categorically saying they've got chronic thromboembolic disease, because you can have a false positive Q scan. Vasculitis, for example, fibrosing mediastinitis, pulmonary artery sarcoma, in fact anything that's going to obstruct the pulmonary artery can give you a perfusion defect. So if you've got a positive scan, you plug them in the treatment, the diagnostic pathway of chronic thromboembolic disease group 4 pulmonary hypertension, sit back and think, what is the next test? Because you are going to need a next test, and that next test is going to be some form of cross-sectional imaging. It doesn't matter whether it's CT, MR, whatever it is, you're going to need an anatomical test to tell you why they've got a perfusion defect. And for that simplistic approach, it's a no-brainer, isn't it? If you're not asking much of the test, you're just asking this test positive or negative. And that's where you need education of the nuclear physicians and radionuclide radiologists who are looking at the perfusion scan. At this diagnostic stage, we are not interested in the number of defects or the extent of the defects or the severity of the defects or the distribution of defects. We just want to know, is there a defect or is there no defect?
And it's such a simple question, it can lead a patient into a very well known, a diagnostic.
And once you have your answer,
right,
they get referred either to an expert PH center or to an expert CTEPH center. That person at that point can say, I want a CT.
Now,
yes,
and that point, I've had discussions with radiographers that says, well, why do you need a VQ?
Yes.
I mean, we have an expert, CT. CT can tell you everything.
Yes.
True. I mean, CT can tell you a lot of information, but having practiced pulmonary hypertension for over 2 decades, I have seen so many instances where, looking back with a known patient that I've diagnosed with CTEPH, where there was a CT done, a few years ago,
Yeah.
where it wasn't obvious, but
Yes.
if you look, there are signs that the patient had chronic disease.
Yes.
Now, hindsight, I understand it's
Yes.
always much clearer, but I guess my question to you is, for patients that just get nothing but a CAT scan, to not get the VQ scan, what is your message for that scenario where the CT being so much more readily available and the VQ is not? I mean, how do we work with that system?
So CTPA is one of the most common radiological tests performed worldwide. Again, it's not the technique that is at fault, it's the reading of it that's at fault. People are not trained to look at CT with the clinical context of chronic thromboembolic disease.
Right.
But what my message would be, a positive CT is good, but if you've got a negative CT, it does not rule out chronic thromboembolic disease, because if the disease is at a subsegmental level, if you've got a truly small vessel component, CT may look deceptively normal.
Right.
In terms of the pulmonary vasculature may look deceptively normal, but they have got significant small vessel disease. So use CT cautiously. That's my first thing. But the second thing is, even if the pulmonary vasculature is normal, look at the heart on a CTPA. If you've got right-sided chamber dilatation, if you've got reversal of the septal curvature, if you've got a patient with mosaic attenuation pattern, they should start to ring alarm bells. Say, this patient has probably got something wrong with their pulmonary circulation. We can't see it because of the fact that you can't see much beyond the fifth order segmental vessels, but they probably have got the disease. So my message for CT would be, it's a most exquisite test to delineate the pulmonary vasculature, but technical limitations means that we cannot see the subsegmental vessels clearly on a routine CTPA. So if you've got a negative CTPA in a patient with pulmonary hypertension, do not forget they could have distal thromboembolic disease, and that's where the Q scan gets in again.
And no wonder this is a disease where you really do need the multimodality imaging
Yes.
to look at the anatomical and functional in many different ways.
Yes, you are getting complementary
Yes.
information
Yes.
from each of these modalities. The thing to remember is, you don't need to use all of those modalities, but you have to pick wisely. And the picking wisely is not just in terms of equipment, but also in terms of expertise.
Absolutely.
If in your institution you have the best equipment, but you don't have an expert person to read those findings,
Yep.
then I'm afraid an all singing, all
Yeah.
dancing machine is useless.
Yes.
Yes.
Totally
So
agree.
you have to pick the right equipment, also have the right expertise.
And getting back to our first line of thought, in order to increase awareness and to ability for us to detect or pick up, the patients who may have CTEPH,
Yes.
I think your point about increasing education
Yes.
to the internist, emergency room physicians, ER, to the pulmonologists and cardiologists, to this condition does not readily present itself.
No.
Unfortunately, it has a way of just sort of hiding itself until it becomes
Yes.
sometimes too late for us to do anything meaningful.
It's a very neat disease.
Yes.
Once you understand the pathophysiology, it's fascinating. And you have right now the means to diagnose it. You just need the awareness so that you use everything that is available to you. You don't have to invest in anything new. You just have to use what is already available to look for the disease. And once you start looking, believe me, you will start to increase the number of
Absolutely.
patient referrals.
And in that kind of a little bit a change of topic, but I mean your career. I mean, looking at your CV, it's a very you've accomplished so much in this very focused area of
Yes.
pulmonary vascular disease, and with using multimodality imaging. How did you choose to come to be an expert in this field?
It's a very simple answer to that, in that I trained to be a cardiac radiologist. I'm a cardiovascular radiologist, and I was fortunate enough to train in Cambridge with a fellowship in Papworth Hospital, which happens to be the UK's only hospital doing pulmonary endarterectomy. So once I finished my training and took up my consultant post in Papworth Hospital, it so happened that the clinical setup was already there. They were already doing the surgery. They were already doing, you know, the multidisciplinary team decisions. So I got appointed, and I'd already been exposed to it in my training stage, and I was fortunate enough to continue to take on the role as a lead radiologist. And I have to say, this disease, more than anything else, the clinical context is so important.
Oh, yes.
And from a personal point of view, I learn a lot more by going to the CTEPH conferences, which are clinical rather than radiological, because the radiology is pattern recognition. It's there or it's not there. That's simple. But in the last 2 years, we have seen so much advances that has increased our understanding of the pulmonary circulation. And you go to those meetings where you've got experts, clinicians like you, who tell you why do they want to diagnose the disease. Because diagnosing a disease is an intellectual curiosity. It's what do you do to the patient once you've got the diagnosis. That's what matters. And as a radiologist, once I understood this is a treatable form of pulmonary hypertension, it would be negligent on my part not to pick up the disease. It becomes so much more easier to go back into your day-to-day practice and put in what you've learned from these conferences into your day-to-day working practice. And hence I would encourage all imaging specialists who are going to get involved in CTEPH, go to a clinical conference, learn why it is important to understand about the disease.
Great message.
Right? Once you realize you can cure a patient, it becomes a no-brainer. You go back and say, right, I'm all enthused. I know I'm going to look at my CT, I'm going to look at my VQ with a new pair of eyes. You will have an increased amount of diagnosis. So much so that you're now then going to turn to me and say, stop it, we can't have any more of these patients.
Oh, Deepa, thank you for all your experience and your dedication and your passion. It's truly appreciated.
Thank you very much, Myung.
Thank you.
Thank you.